Hi. Okay, I'm going to go ahead and start with and I don't know why it's moving along, but hold on. Let me get it back. With a Unit 2 recap, and like I have broken down in here, you're going to have 6 pain questions. Periop, there's a total of 16, and I believe there's something like, hold on a second, there's, come on, something like 3 intra-op, 6 pre-op, and 7 post-op questions in there, okay? And then the anemia, there's a total of 5 questions in there. So we'll go ahead and start off with pain. And as you know, pain is what the patient says that it is, and it happens when the patient says that it does. Okay, and so very important, of course, would be the pain assessment. Like I've been saying, more than just can you rate it on a scale of 0 to 10, tell me what it is. More than just the intensity. So we want to know what's the location so that we can determine whether it's somatic, visceral, cutaneous, or psychogenic. So, location is important because a patient may suffer different types of pain, especially when we're talking about surgical patient. We want to make sure that indeed it is incisional patient each and every time that we are medicating for pain. Does it radiate? Is it referred or localized? Is it projected? So make sure that you do review those terms as to what it means. What is the intensity? This is where the level comes in, whether it's a 0 to 10. We know that up to 3 it's mild pain, 4 to 6 is considered moderate, and then 7 and above is severe pain. Use the faces if that's more appropriate, and it doesn't have to be a child or an elderly person that's confused or with some dementia. Faces work really well. What does it feel like? Ask them to describe the pain. Is it dull, aching, sharp, burning, bright? Some people describe it as bright. Does it feel like pinpricks? What exactly does it feel like? And then what makes it better? Anything that makes it better? What makes it worse? What have you tried in the past that's worked, not worked? And when does it tend to occur, or when does it tend to increase in intensity? So assessment is very important, and remember that we need to assess before and after our interventions. And depending on what your interventions were, if you intervene, let's say an IV medication, then you want to assess within 30 minutes to see what the effectiveness. If it was orally or PO, then of course up to an hour. But remember those other interventions that you can have too, with a positioning, promoting comfort in that way, other than just medications. All right, so opiates versus non-opiates. We know that for mild pain, we advise that patients use non-opiates, and we know that the most popular ones are the NSAIDs, all right? We have to teach the patients how to take NSAIDs and about the frequency of taking NSAIDs, because we tend to overindulge, just like we have patients we say they take too many opiates. There's a lot of people who take too many NSAIDs, so we have a major problem with that is that it causes irritation. Gastric irritation can cause a gastric ulcer. So we need to teach them about that, to take them with food. Opiates, remember that opiates will not work for neurogenic or neuropathic pain, alright? So it works very well for noxious pain, when we can identify the injury that is causing the acute pain, such as I slam my thumb in the door, or my surgical incision hurts, that's the injury, or my sprained ankle hurts. We can identify the injury causing that acute pain. So opiates, like I said, are very effective in using for noxious type pain. They work beautifully. Now we need to keep in mind, we need to teach the patient too about complications that can occur with the opiates, such as depressed respirations. And keep in mind what would be the signs and symptoms that would tell you, if you have somebody that has a respiratory rate less than 12, that's the parameter there, less than 12, then of course we want to check their level of consciousness, all right? We want to see, are they easily arousable or not? Do we just need to stimulate them, or do they need just a little bit of oxygen? What exactly can we do? We want to see if they are arousable. So check the level of consciousness. And of course, complication then would be a diminished level of consciousness. Constipation is the other one, and so we need to teach them to do what? To hydrate well, and add fiber to the diet, or take stool softeners. And then urinary retention, because of the relaxation of the smooth muscle, they'll get the constipation and the urinary retention. So we need to be assessing for that at all times. Surgical acute pain, things that will help in managing it. Probably the most difficult to manage is the abdominal pain that occurs, when you have abdominal type surgeries. So you have the distension and the abdominal pain, and you have the gas in there, and the gas is causing the abdominal pain, really. And so what they want to, and this is what we do, we give them more and more opiates, and that's just going to aggravate the situation, because remember what the opiates are doing to the GI tract. They're keeping peristalsis from occurring, so that just adds to the abdominal distension. And so yes, we do want to medicate, but we want to make sure that we add ambulation in there, because if we don't, then we're not going to take care of the problem. And we need to teach our patients, and probably this should occur when we're doing the pre-op teaching. It should happen before they go to surgery, about early ambulation, because they're not going to want to ambulate, but that's the best thing. And that pain, it will be very difficult to bring it under control as long as they don't ambulate and start passing that flatus, so that they can go ahead and get rid of that gas. All right. So we need to teach them about that. We need to teach them how also early ambulation will help, not only with the pain, but with the respiratory status, with their breathing, to prevent pneumonias, that it will help with preventing deep vein thrombosis, all of those benefits that we get. And also it promotes healing. And so we need to teach to that, and we need to think about using ambulation here, like I said, for managing acute pains, acute surgical pain. If they're going to be on a PCA pump, or managing the pain, of course, patient education is very important. Everybody needs to know, and I mean everybody, the family and visitors of the patient. Patient needs to know, I'm going to be the one that's going to be managing this. I'm the one that presses the button, and nobody else can. And family needs to know that they can. Make sure that the signage is up on the pump, and then teach them about, pressing the button. Reassure them that it has a lockout, so they're not going to overdose themselves. All right. The lockouts, of course, are usually how many minutes? They're up to 15 minutes, 5 to 15 minutes. And when we're programming the pump, it is a narcotic, so we do need to have 2 nurses to program the pump. Usually when the patient is on a PCA pump, we have a PRN order for an analgesic for any breakthrough pain, and we need to teach them about that sometimes that does occur, and it's not that the PCA pump is not working, it's just that we do have incidences, and we do have a PRN medication for that. Okay, chronic pain is probably the most difficult one for us to manage. It is difficult to assess. Usually, because it is so difficult to assess, it leads to healthcare providers doubting the patient's pain experience, and that's because we don't see the typical behaviors we expect to see with pain. And those typical behaviors we expect to see are the ones that we see with acute pain and not chronic pain. When we have chronic pain, patients may not exhibit the tachycardia, the tachypnea, the elevated blood pressure, the dilated pupils, the diaphoresis that occurs with the sympathetic nervous system response that we have with acute pain. With chronic pain, the body no longer responds or triggers the sympathetic nervous system to respond to the pain. And so there are other effects that we assess for. Sleeplessness, an individual that seems to be depressed, exhibiting feelings of helplessness, hopelessness, resignation that the pain's going to be there, can't do anything about it. They will have a depressed immune system. They may be malnourished because they're not eating adequately, and they may exhibit those drug-seeking behaviors for unrelieved chronic pain. Oftentimes, and studies have shown that drug-seeking behaviors can usually be related to unrelieved chronic pain rather than I want to get high. Okay, so we need to do those types of assessments for chronic pain. Actually, it is best to refer the patient that has chronic pain and we're having difficulty obtaining pain relief for that patient to a pain management specialist rather than for the primary care physician or the family doctor or whatever to be trying to manage that pain. It's really best. They're the experts at it. It is best to refer them to a pain management team or a pain management specialist. How do you feel about schedule versus needed, as needed pain medication for chronic pain? What works best is the scheduled versus the as needed, especially if the as needed is going to be nurse administered. All right, so it's best to do it around the clock on scheduled times than do it PRN. There's a lot of behaviors that occur with chronic pain, such as the patient may have a fear of addiction himself or herself and may not be asking for that pain medication as needed, and then allows the pain level to get to an intensity level that then it's very difficult to bring it back under control. So it's really best to do schedule versus as needed pain medication management. And then when we have malignant pain, schedule is the way to go. Alternative or complementary methods, all right? And I'm just going to address some of the methods that are used when we're using the gate control theory or when we're using the central biasing theory. The central biasing theory is the one where it's the feel-good actions. We have the release of endorphins and serotonin here. And so techniques that are used for that can be such things as music therapy, aromatherapy, therapeutic touch, massage, biofeedback falls in there, hypnosis, all right? Those are the types. They tap into the release of endorphins, making the person feel good, and that's a method that is used for pain management. The gate control theory, we're using noxious stimulus to race to the gate. Remember, it's in the dorsal horns of the spine, and so we use this fast transmitted stimulus to close the gate, all right, to get to that gate first, and by getting there then it closes the gate to the slower moving pain, the pain that the patient's feeling. And so what are the techniques that we use? We use things that things like acupuncture, acupressure, ice rubs are in there. TENS units are very popular. All right, the use of TENS units. A word on TENS, they are commonly used. Make sure, the patient requires very good teaching. We need to teach them about proper maintenance and care of the unit to make sure that the batteries are always working, for them to check batteries. And one thing is that the intent is not to dial it up as far as they possibly can. We start low and we build up with it. So we teach them to dial it to the point to where it creates a sensation of the feeling of pins and needles, all right? And then from there they can go ahead and be adjusting the intensity according to the response they have to the TENS. Okay, that's it on pain, and now we're going to move to perioperative care, starting with a pre-op phase. This is a phase where the focus is on patient preparation for the surgery, and of course patient education is a piece of that. What do we educate on? Well, for sure the procedure, and that's to be done by the surgeon, which means that when we receive the patient the pre-op holding, if the patient does not understand, or at any point preoperatively, and the surgeon has already explained to the patient, and oftentimes we're the ones that have the consent form for the patient to sign. And so when you question the patient doesn't seem to understand the procedure that's to be done, we stop everything, we notify the surgeon. The surgeon needs to come back and make sure that the procedure is properly explained to the patient. And you may want to witness that so that you know exactly what was said to the patient, and then you know what to expand on or clarify for the patient. So The other thing is make sure that this teaching is done before any sedatives are administered, and certainly that the consent form is signed before any sedatives are administered, because if sedatives have already been signed, then that consent form is not valid. All right. We're going to teach them as to what drains and equipment to expect to be used post-operatively, right? So they're going to come out with an NG tube. We explain the purpose and how we're going to maintain it, how maybe it's, I wouldn't say, oh, it's going to hurt or whatever, but maybe it's going to feel uncomfortable. But what the intent is, and any other drains, the purpose and what we expect to be obtaining from those drains and stuff. Equipment, are they going to have IVs? Most probably yes, of course. IVs infusing and so forth. We're going to teach them about pain management. They do need to know that, they will have their orders. If they're going to be on a PCA pump, this is the time to be teaching them about the PCA pump. But they will have pain medication orders, and because we want to maintain a level of comfort for them, because we're going to expect them to be up and about. We are going to employ early ambulation. We're going to be doing very vigorous pulmonary hygiene with a coughing and deep breathing and incentive spirometry. When you teach them, and this is the place preoperatively to teach them how to cough and deep breathe, also don't forget to include the splinting. And then teach them about the incentive spirometry. Usually respiratory therapy is the one that comes in to teach them about the IS, and we reinforce it. So just make sure that they do understand how to do it properly. Okay, so preoperatively also assessment. When we receive the patient in the pre-op area, we're going to assess, do a systems assessment, and of course then we're going to assess any lab results or diagnostic results that come with the patient. All lab results, all diagnostic results, everything goes with the patient to the OR. If there is anything that is significant, we need to report it to the physician. We need to, at this point in time, assess for any risk for malignant hyperthermia. Remember that this is a genetic disorder, so the questions to ask them, if they've had previous surgery, to ask them if it was under general anesthesia, and if there were any problems with the anesthesia, and if so, what were they? And if they haven't had any surgery and stuff, or they don't report any problems, then do they know of any family members that have had surgery and had problems with the anesthesia? Any kind of problems, we want to gather that information and make sure that the surgeon has that information on hand. We're going to assess for, significant findings such as fever, high blood pressure, any abnormal labs. Some labs, for example, if you have a high or a low potassium, that's going to stop the surgery. We're not going to send them into surgery. We're going to correct the hypo or hyper potassium before we send them in. And then there's other findings such as fever or any sign and symptom of an infection, such as fever, that's the common one, will call or will require that the surgery be canceled. We cannot send them to surgery until that is taken care of and we're sure that they are infection free. Alright, then there are some other labs that will not necessarily delay or cancel the surgery, but the surgeon of course needs to know anything that is abnormal. Alright, such as maybe you have an elevated creatinine level. That is significant, especially in an elderly patient, because it has meaning so far as the anesthetic agents are concerned. We know that if they have an increased creatinine level, they're going to have problems with the excretion of the byproducts of the anesthetic agents. Alright, so they need to know that because they may require some lower doses and some adjustments to be made by the anesthesiologist. We verify their MPO status. If the patient did not maintain MPO status, we need to notify the surgeon. More probably it will cancel the surgery. Sometimes it doesn't. We find out, well, the patient only had, a little bit of water or half a glass of water or something like that. But that's a surgeon decision to be made. We want to know if they have taken any medications recently that put them at risk of bleeding, such as NSAIDs or any aspirin products, or if they're on anticoagulants, did they stop them as they were instructed to do, or have they been taking them within the last 24-48 hours, okay? And then patient safety. It's very important because in this area we're going to be sedating them, alright, so we need to provide for their safety. Once the pre-op sedative is administered, the patient is to remain in bed, and we need to make sure that the patient is safe. We put the top side rails up, and we make sure that the wheels are locked, alright, and that the call light is within reach. I mean, we're right there in the area and stuff, but we want to make sure patient is no longer able to get up out of that stretcher or sit down or whatever once we have given the pre-op sedative. Intraoperatively, what we, because there's the team, right? All the members of the team, they all have their roles and responsibilities. For us, where the RN role is the circulator, all right? So one big responsibility that we have, and actually that's it, it's safety. It's safety in the intraoperative suite, all right? Patient safety, that our patient is being kept safe, and environmental safety. So we make sure that everybody is following the protocols that are in place for the OR. Starting with a surgical scrub, that it's properly done. That's about a 5 to 10 minute scrub with an antibacterial. That, we don't contaminate while we're doing the scrub. Our arms are bent upward at the elbow when we're scrubbing, but the arms are passed under a running stream of water to have the water drip off the arms, so we might want to make sure that it doesn't run either towards the wrists or the elbows. The surgical prep, when the patient's skin is prepped with an antibacterial solution, make sure that no razors are used to shave the area. Nowadays, even they may use an electric razor, but sometimes they just clip the hair, and that's sufficient. Sterile fields, that they are kept sterile. We're to watch in the OR, we watch each other for any breaks in sterility, and there are protocols in place, such as our arms never go below waist level. Anything below waist level or behind us is considered contaminated. We never give our back to sterile fields. If we do, then those fields are considered contaminated. All right. So we're always policing each other to make sure that we maintain sterility in the OR. We want to prevent unnecessary hypothermia for the patient. We know that the temperature is kept cold, and we do give liquids that are cold to the patient and staff. We do bring down the temperature some, and that's to lower the metabolism so that we decrease the oxygen demand while they're in surgery, and also it limits bacterial growth when we have a cold temperature. But we need to make sure that we do not put the patient at risk by lowering the core temperature too much. And so even though that we maintain a cold environment, we want to make sure that we protect the patient. That means all extremities are covered at all times. Sometimes they even use some heating devices at the head and stuff of the patient so that the core temperature is not lowered too much. All right, so we're always vigilant to make sure that we do not have any unnecessary hypothermia, and that we don't expose those extremities. Talking about extremities, especially with your elderly, we make sure that we support and pat those extremities, use extra padding for them. We make sure that we lift patients into position. We do not drag or slide them across the OR table, and that's to protect their skin. Remember that just having a surgery and being on that OR table for any period of time will cause a pressure ulcer, and it's not uncommon for patients to come out of the OR with a stage 1 pressure ulcer. We're going to assess for malignant hyperthermia and be ready to prepare an antidote. So how do we assess for it? We're always monitoring the patient. All of us monitor, even though the anesthesiologist is the one responsible for monitoring all the monitoring equipment that we have in place, the heart, rhythms, the oxygenation, the respiratory rate, the blood pressures and stuff. but it's all of our responsibility. So, you know, be on the alert for any tachycardia or any extremely elevated temperatures, any brown or discolored urine, cyanosis on the patient, or even muscle rigidity. Those are the signs and symptoms of malignant hyperthermia, and be ready to prepare the antidote, which is Dantalin. That's the only antidote known for malignant hyperthermia. Okay, so then we move from the intraoperative to the post-op phase. The PACU, we have immediate, and then we have the surgical floor. In the immediate, of course, it's ABC, and I added a D here, all right? Airway, we always assess and maintain an open airway. We may be receiving them with oral or nasal airways. Sometimes they even have their endotracheal tube in place. But if they just have oral or nasal airways, we need to make sure that airway is open. That means the chin lift, head tilt, and that their head's not slumping down and stuff, all right? So airway. Breathing, if it's depressed, that means less than 12, then we need to immediately assess O2 sats and their level of consciousness right away. And make sure that they stimulate them, they do respond. If they don't, you know, then we may want to increase the oxygen. We want to keep the O2 sats above 95. Remember, the patient will be receiving oxygen in the PACU, so we don't want to, you know, an oxygen sat of 90 is not acceptable. We want it at least at 95. Then we look at the dressings, and we mark the dressing with our initials, time, and date. We mark the margin of any drainage so that we can continue doing subsequent assessments. We're going to assess for the patency of any of the drains and make sure that verify what kind of drainage is coming out of those drains, and make sure that they are properly secured. Vital signs are done on admission to the PACU, and then we do them every 5 minutes times 30, and then every 15 minutes times 30, and usually by that time, 1 hour's time, they are ready to be discharged to the floor. Remember that, and this is one of the things for you, remember that general anesthesia is the one that affects all systems, all right? And that regional and topical anesthesias do not, all right? So if you have somebody that received a regional anesthesia, you're not going to be assessing cardiovascular status. You're not going to be assessing respiratory, their lung sounds and stuff like that, because they don't have those general the effects of the other systems as does the general anesthesia. Okay, so you know, everybody gets vital signs done upon admission, and then depending on the anesthesia, we take it from there as to what we need to do, and we're always looking at ABCs, right? Okay. The surgical floor, then, we continue with assessing the airway, circulation, neurological status, level of consciousness, and temperatures on the floor. Usually on the floor it's Q15 times 2, and then Q30 times 2, and then depending on what the doctor has ordered. He may order it initially Q4 hours, you know, for the rest of the shift, or, you know, but he won't go to daily or once a shift from there, all right? So we gradually taper off the frequency of monitoring vital signs. Every time that we monitor vital signs when we receive them, of course we want to check the wound. We want to check the drainage tubes when we receive them and get report from the OR nurse. We want to get report about not only the vitals, their level of consciousness, but what does the wound look like, what has it drained, what did they mark, what's draining from the tubes, what kind of drainage tubes they have, the IV order, all of those things, all right? So a complete picture, and we check these things on our own too, and then continue monitoring it throughout the rest of the shift that we have the patient. Pain management is going to be very important. Actually, pain management starts in the PACU. So if the patients complain of pain in the PACU, we start medicating them there. Nowadays, if they're going to have PCAA pump, they come with a PCA pump, usually, to the floor. The PACU staff will start the PCA pump. We want to make sure if they receive general anesthesia, especially, we assess them for nausea and vomiting and take appropriate steps to reduce it. We don't want them to be vomiting and stuff like that, especially if they had some kind of abdominal surgery, because they're going to be putting a strain on the sutures, and not only the external ones, but the internal ones. And then, of course, monitor for those complications for the patient that received general anesthesia, such as urinary retention, constipation, depressed respirations. Let me see, I think I have it over here, the other complications that can occur, all right? DVT is one of them. We're always going to monitor and take steps to prevent complications, such as the best thing is the application of sequential compression devices, or SCDs. The next best thing is the application of TED hoses. But if they only have TED hoses, then it's very important that we teach them about leg exercises, that they do a dorsiflexion and flexion of the feet to mimic what would happen with walking, the contraction, relaxation of the calf muscles. And then, of course, the other thing would be early ambulation. And then they usually don't start within the first 24 hours of surgery, but after that, prophylactic heparin, a low volume molecular heparin, prophylactically to prevent DVT. But the best thing is to have those compression devices and get them out of bed, have them walking around. The other complication that occurs, atelectasis pneumonia, usually 2 to 3 days afterwards. And what we do to prevent it is the coughing and deep breathing, the incentive spirometry, and early ambulation. Signs and symptoms of atelectasis would be, usually we see the rapid shallow breathing. The O2 sats may drop some, probably will, and when we listen to their lungs, we'll hear decreased breath sounds. The other thing is that they may have a low-grade temperature elevation. Those are the first signs of atelectasis. If they start getting short of breath and cyanotic, then it's more severe. It really has increased in depth. Constipation is the other complication that does occur, and of course hydration. IV hydration, once they are on oral fluids, then we're going to add stool softeners to their diet, so to speak. And then, of course, the other thing, early ambulation. Wound infection, like I said, this occurs once we start doing dressing changes, 48 hours, 48 to 2 to 3 days, okay, 48 to 72 hours. And so we're going to monitor WBCs. WBCs are going to go up some, but not extremely high, and it's from the inflammatory response. So we do expect a little low-grade temperature, no greater, it doesn't go to 101 and above, okay? We expect that. We expect a little bit the elevation of WBCs because of the inflammatory response. But if they keep on climbing or they get extremely high, and then we see changes in the wound, such as the drainage or a change in color of the drainage, or now there's a foul smell, signs, and it's reddened, it's hot, it's painful, then most probably there is an infected wound, and to expect to culture the wound, we need to culture the wound before antibiotics are started, okay? The other two are dehiscence and evisceration. Dehiscence, we need to teach the patient to avoid straining and splint the surgical incision when coughing. We also need to teach them to inspect it, especially if they had surgery like knee surgery and flex areas. Those ones tend to dehisce a little bit more, because of the movement of the strain on the suture line. So be aware, be on the alert for that too. And then evisceration, of course, is when we have the separation of the sutures. Is not just the external one, the superficial ones, but internal ones. So we have the protruding organs through the opening. And so what we need to do, that's an emergency situation. We need to go ahead and cover the wound or the evisceration with sterile saline soaked gauze. Call the surgeon, and if you have them in the bed, go ahead and raise the knees up so that you can decrease the strain, the pull of the abdominal muscles. Okay, those are the most common type of complications. All right, so we're almost getting to the end. The next one here is anemia. And I put on here the hemoglobin levels, right? And we know that they're different for females and males. So anemia is if we have a hemoglobin level less than 12 for females and less than 14 for males, or an RBC count that is below 4.2 for females or 4.7 for males. Make sure that you recognize signs and symptoms of anemia. Oftentimes, especially with the elderly, we have silent anemia. They don't know. There's no evidence of, active bleeding and stuff like that. So a lot of times, they have melena, they have an upper GI bleed, they have melena, but, they don't know what it means. And so they may start complaining of some weakness or lightheadedness, or they fatigue easily, and now they're having to take naps during the day where they didn't have to before, things of that nature. The more severe the anemia gets, the more obvious the signs and symptoms are going to be. So you'll have that, that tachycardia, the orthostatic hypotension, tachypnea, maybe even dyspnea on exertion, changes in mental status. You may have cool, pale extremities, and then if you do O2 sats, they're going to be decreased. Okay, so make sure that you do review signs and symptoms of anemia. One of the things in reading about anemia, it's not necessarily, anemia doesn't mean that it's a disorder. It's more of a sign or a symptom that occurs for certain disorders, all right? So you may have anemia because it's a GI bleed, or you may have anemia because you have problems with your liver, or so it's really not it's a result of a situation, and it's not necessarily causing the situation. All right, so it was really interesting. That's why when we teach about anemia, and I say, I'm not going to be asking you if it's for you to recognize whether it's pernicious or aplastic or whatever. I want you to get the concept of anemia and recognize what would be suspicious for anemia so that you can further investigate. Okay, so those are the causes of anemia, and I put this backwards, by the way. This should have been the first slide. The causes would be an inadequate production of red blood cells. It can be a disorder or chemically induced, or the loss of red blood cells, from GI bleeds being the most common in the elderly and in the adult population, because we use a lot of NSAIDs, all right, and we do not take them properly. We need to take them with food, and oftentimes people take NSAIDs on empty stomachs. Okay, sickle cell disorder. It is genetic in nature, and what happens is that the body makes sickle cell or sickle-shaped red blood cells, and this red blood cells is sickle cells, or HBSs, kind of clumped together. And as they clump together, then it further affects their ability, or the ability of the hemoglobin to carry oxygen. Okay, so they contain abnormal hemoglobin that gives it that crescent shape. They sickle, and so they will not carry oxygen as normal hemoglobin does. So what's the end result of not having enough oxygenation nutrients? We have hypoxia of the cells all over the body, all the cells. All right, we say that a sickle cell crisis occurs when we have hemoglobin, sickle hemoglobin that's 80% or greater. So that, when you have 80%, that's almost all of your red blood cells are sickled. Okay, so one of the primary manifestations of sickle cell crisis, or even sickle cell disorder, because some patients are in chronic pain, they're in pain all the time, but the crisis is severe pain from the cell hypoxia. So how do we treat it? Two methods. We treat it with scheduled IV opiates, the morphine sulfate or Dilaudid, or Dilaudid. Sometimes they alternate them, and this is done for the first 48 hours, and then we taper them and give them orally. We do not give them IM because they can be poorly absorbed because of the sickle cells, and so it may not be carried in the bloodstream like it would need to be carried because of the sickling. Okay, so it works better to give it orally. So first 48 hours, schedule IV, morphine or Dilaudid. It can also be a PCA pump, and then we taper and give them orally. The other thing, we want to dilute this sickling, this clumping of the cells, so IV hydration. And usually the rate, it's given at a fast rate, it's usually at 250 mLs per hour, again for the first 48 hours, and then we start tapering it off as we start increasing the PO intake. The other thing is that patients with sickle cell disorder are at a greater risk for infection, all right? And that's because cells don't get the proper nutrients. You know, cells depend on the red blood cells to carry nutrients and oxygen to them, and when you have a sickle cell disorder, then you have less than desirable delivery of nutrients to your tissues. All right, that's it. That does it for the coverage today.